My name is Aisha Delaney Brumsey. I'm really excited to be here. I'm the Chief Strategic Growth Officer at SAMHSA. And our featured speaker is Brett Beckerson with National Council. And he will be speaking about CCBHCs and the 988 Continuum. Next slide. So as always, if you want any information about the 988 Jam and get the link to the Zoom, go to talk.crisisnow.com. It has the Zoom link there. It also has where you can get the materials to promote 988, virtual backgrounds, t-shirts, etc., and the information for the upcoming show. And also it has the Crisis Jam highlights. I can't tell you how often I'm going to this to get resources or look back at old episodes, to send things to colleagues. This is just a tremendous resource for the field and for all of our work. And next slide. So also, if you're having some trouble with getting the calendar information on, you can go ahead and click the link that Kristen just put in the chat and make sure that it gets on your calendar so that you're here every week on Wednesday, 12 noon Eastern. And as we all know, this Crisis Jam has amazing episodes every week. But if you want to get a deep dive into some of the biggest hits, you can go on the YouTube channel and see some of the top 5 episodes right now in terms of viewership. Number 5, Crisis Receiving Center. The Special Youth Edition has been popular for a long time. It's the #1 issue. And so many of the episodes are cataloged on YouTube. Go all the way through the top 10. I love this slide. What it shows in the next couple slides is that over the time that this Crisis Jam has been running, there have been nearly 400 unique speakers over the 140 episodes that we've had. And what I love about this is it shows both the breadth of speakers, but also the breadth of perspectives and ideas and innovations that are coming from out of the crisis community. But more importantly, if there's someone who's missing from this, if there's an idea, a perspective that you think has not yet been covered, then you should definitely reach out to Karen Jones with a suggestion on a speaker. Soon there'll also be a process on the website to submit ideas for talks, but reach out in the meantime if you'd like to speak, or you have a colleague or a connection who you think would be a fantastic speaker. This is just a wonderful visualization of all the perspectives that have been here. So in terms of some of the news that we're highlighting this week, one of the first ones is a news piece focusing on the disproportionate rates of suicide among particularly Black LGBTQ youth. It's called Still Ringing the Alarm. Just a reminder that for the need to focus on some of the most marginalized and impacted communities in order to ensure that everyone is able to live a full and well life. And so this is a really helpful, although of course, always disturbing article. Next slide. This one was in the New York Times. You can get the link for this and the other news article on Crisis Now, but also in the chat. This was a reflection from a father about the loss of his son. After the loss of the son, a football coach confronts the terrible truth, talking about the impact of the suicide on his life. And actually, Brian Hepburn, are you here in the audience yet?
Yes, I am. Yeah, and it wasn't a suicide. It was his son was killed in a shooting when he was 23 years old. But the father was a coach. He'd been in multiple different jobs across the country, and his kids were all involved in football. The family was involved in football, and the father wanted his son's brain checked because his son started going through significant changes when he was in his late teens, early 20s. And what the autopsy showed was that the son was suffering from chronic traumatic encephalopathy. And just so that people remember what that is, that's usually associated with boxers or with football players who have had careers. This was in a 23-year-old. So the reason that we're highlighting this is because of how important it is to look at childhood sports and look at, are there things that are happening, for example, repeated head injury, that may be putting the individual, the child, at risk for substance use disorder or mental illness later on. We know that there's an association between traumatic brain injury and substance use, traumatic brain injury, and mental illness. So looking at from a prevention standpoint, and this is the issue for all of us on the call, what can we do to make the lives of our children safer? We understand there's a reason for contact sports, people love it, but is there a way to do it so that we're not going to be putting our children at risk later on?
Thanks very much for that context, Brian. I think that's a fantastic point and a reminder about thinking through the potential causes of distress and also what we can do to be really thoughtful about prevention, more importantly, particularly in young people. So thank you. Another news story is really focusing on the mental health toll in the Maui fires. I know that as we're seeing many more natural disasters occurring, we're getting a lot more information about the impact of those disasters on people's mental health, as well as the stress associated with worrying about those disasters on mental health. This is a really important article as well. So as always, if you're interested in the SAMHSA Partner Toolkit with free resources promoting 988 in multiple languages, wallet cards, magnets, etc., you can receive them here, get them sent to you for free. A great way to get out the word in your community and in your network. Also, if you're interested in 988 Crisis Jam t-shirt, one of the best ways to get one is actually to be a trivia hot seat contestant. And you get to choose which of these posts you get, and you get it sent to you for free. So just a plug, if you're interested in being a Trivia Hot Jam contestant, reach out to Karen Jones and you'll also be getting a t-shirt. This is a setup here for our Trivia Hot Seat contestants' parents, a short video to get us kicked off.
I'm a person that is both formally educated and I have that lived experience. And yet today, my lived experience as a person in recovery from mental health challenges and substance use challenges, that living experience that I have is actually what I use most.
All right, Terrence, I'm going to call you up to the Trivia Hot Seat, so brace yourself. And this is a special edition. I was briefly reminded that this is one of these things is not like the other. So just like in Sesame Street, where we all learn some of our most important life lessons, you're going to have to choose which of the responses is not like the other. So I feel for you. I think this is a challenging one, but as always, you can get information from the crowd. You can phone a friend. So you have help here.
Okay.
All right, let's get started. How? Dr. Sanjay Gupta has researched some of the world's longest living people and looked for common elements like diet, physical activity, having community, and the Ogimi village added another theory. So the question is, poetically waking up to joy. So which of these things is not like the others? Eudaimonia, ikigai, risandetra, and the Welsh mirth. I have deeply bad language skills, so excuse the pronunciation.
Not a problem. So this is, I know, I have a gut reaction. The first reaction that I had But then it's French, and I know French, and actually it doesn't work. So, so a reason to be, is raison d'etre. So we'll knock that one out. And now I'm completely in guessing mode. Seriously.
I like a gut reaction. I'm here for a gut reaction almost always.
Yeah, well, Ikigai is also, we'll put that aside because that's I'm familiar with that. So now I'm stuck between eudaimonia and Weltschmerz.
Well, do you want to phone a friend or see the audience suggestions?
About the audience, yeah, and then I appreciate that. Yeah,
So,
you're in the same place I am. Okay. So all right, well, let's go with the audience by 3%, and I'll join that, maybe make it 4%, and let's go with A, eudaimonia.
all right, A, eudaimonia.
Done it. Okay.
Listen, well, this was a tough one.
So, the gut one, that was it.
You should have gone with your gut.
My gut, I had a great running streak, and now I but thank you so much for letting me do this. And I love that this is very up my alley.
Absolutely.
Waking up with joy is I just really quick, I always talk about when I'm worshiping that first cup of coffee, I get a burst of joy every day. And I'm just so grateful for that.
I appreciate that. It's a great reminder to really cultivate your joy, cultivate your bliss, and let that drive your day. So thank you so much. I'm sorry you lost, but listen, I lost in the prep. Many of us lost this one. You won by being here. So thanks, Sharon.
Thank you. Thanks, everybody.
So this is just a follow-up on the trivia hot seat, but Ikigai doesn't need to be lofty or complicated. It's better not to stress about it. It's largely just an activity that will blissfully keep you busy until the end of your day. So just something that, like Karen says, wakes up your joy on a daily basis. And here are some of the examples. I think you all can choose which one is not like the others. It wasn't in the article, but I think we're all also excited about. So it's a great quote. It's a reminder to hold our door closed. And now I'd like to call up Maddie Stoltz for the lived lens. So Maddie, as I understand it, you're a NAMI Next Gen alum and also a college student. Really here to talk about your own experience. So thank you so much. I will open the floor to you.
Yeah, absolutely. Thank you so much. And thank you for inviting me onto this. This is just another example of how many people are dedicated to this cause. So, and I wanted to talk about, as from what I understand, you guys talk about on this section about how do we feel like we've achieved this promise of 988, which is, care that feels like care. And to that, I do think that the answer is when you pick up the phone to call 988 and you get answered by people that sound like people. And these people, I have called 988 many times. I've had an experience where I've had to call for myself, where I've had to call for my, my friends, my peers. And I remember, there is sort of a algorithm to it in a way. There are some people that will follow the script and have sort of a sort of same tone throughout the whole thing. And that is what has largely drawn me away from crisis lines like that. But I remember that about a year, maybe 2 ago, I was at my girlfriend's house, and I don't remember what led to me wanting to call a crisis line. That often is how it goes. And, crisis is heat of the moment. You don't often remember what leads you to that moment. But I remember I was feeling really bad, and I had left my girlfriend's house to go home, and I ended up just driving on the interstate, not knowing really why or what I was doing there. And so I picked up the phone and I called 988. And the person who was answering, she started off with those same, scripted questions, scripted responses. It was pretty monotone, and I was getting pretty frustrated because these people, that are calling this line, especially youth, especially people that look like me or are the same age as me, we are calling in a frenzy. We're calling in a panic. We don't know, why we are where we are or what we're going to do next. And so being responded to by someone who, sounds like they're, in the 6th hour of their job, it's hard. And you want to hear people that sound like people. You want to hear people that sound like they care. So I remember, driving down this interstate, talking to this lady, being like, I just don't understand. I don't even really want to be talking to you right now. I just wanted something to do to get myself off of this path. And she had asked me to pull over. And I could see as we were continuing this conversation that she was opening up more and more, and started to talk to me like a person. And that was truly what changed me that entire night. That's what put me on a greater path towards mental health and mental wellness. And hearing that person talk to me like I was their daughter, like I was their friend, like I was someone that they cared about, was so incredibly important to my overall journey. So getting people that respond to 988 calls, that respond like that, respond to people, to hear them as people, not just another call, another number, another statistic. That is how I see 988 developing and becoming this promise that we all want to see.
Maddie, thank you so much. That was eloquent and powerful, and a reminder that, as you said, the care that feels like care really starts with people bringing their full selves and connecting to other people in an authentic and meaningful and loving way. And Maddie, I just want to thank you for sharing your experience and bringing that perspective to this jam today. So appreciate you.
Thank you.
And now I'm really excited to be able to bring up Brett Beckerson from the National Council for Mental Wellbeing to talk about the CCBHC model as part of the crisis continuum of care. Brett, I'll turn to you.
Great. Well, thank you so much. And thank you all so much for having me. This is my first Crisis Jam joining, but longtime fan and really excited to be a part of it. So my name is Brett Beckerson. I'm a social worker by training at the National Council. I work in partnership with states to help them both understand the CCBHC model and think innovatively about how to tailor it. So the kind of two major things I'm going to do today is talk about like the updated criteria and some proposed updated payment, and really how that can be an opportunity to kind of leverage, amplify efforts, and also pay for efforts related to 988. So I think that's something that'll be really timely as we get into legislative cycles and budgetary cycles next year. But we can go to the next slide. And I will preface that I have a number of slides in this deck, but I want that to be a resource for you all. So if I touch on something just slightly, apologies, but want to make sure you all have that information and content. So when we think about the CCBHC model, I want you to think about kind of three different things, and I'll describe them in a way that I think really resonates with folks. One is integrated services. So that's integrating mental health and substance use within a one-stop shop for care, but it's really integrating those services anywhere into the community. So integrating them into a school, integrating them into the justice sector, integrating them into, and I love that this question was asked, so I will better define this. So it's certified community behavioral health clinic model. Apologies, I say the acronym every day and it just kind of rolls off the tongue now without giving a lot more context. So the certified community behavioral health clinic model, it provides integrated mental health and substance use care, both within the four walls of the clinic, but also out into the community. So again, if you're in a school, if you're in a justice sector, if you are in a place that provides either housing or if you're an encampment, even in your own home, it's a place where Medicaid services can be reimbursable should that person, be eligible for that, and those services can be provided. The cost related to it, so it's not just the cost for the service, it's the cost that really requires delivering care, right? So the technology behind it, the time it takes, just the overall connectivity, kind of making sure that those folks who are providing those services are paid adequately and that we can kind of track how that's working. And all of that from the kind of quality care component is then measured to make sure that it works along those lines. When we think about the CCBHC model, again, the Certified Community Behavioral Health Clinic model, there are 6 criteria. Those are here to the left of the screen, and then some key elements to it. So it has to serve everyone regardless of ability to pay. Services must be provided within with some timeliness. So like that maximum kind of 10 days for routine services. They must be able to provide a mobile crisis response, so 24/7 mobile crisis response, and they must partner with organizations like law enforcement, emergency departments. So it's really creating a web of connectivity within the community that is tailored for that community and the populations they serve. So when we're thinking about kind of where and how some place that someone would want to go, the CCBHC model is really what that is. Actually, I'll take a quote from Anita Everett, who is in leadership at SAMHSA, and she describes the CCBHC model in this way. If there is someone that you love who has a mental health or a substance use challenge, the CCBHC is where you want them to go. And so as we're looking at some of these innovative and new things that are arriving, right, like around 988 and other efforts related to mental health and substance use, CCBHC can be a vessel, can be a vehicle to be able to support in a more and better way how to pay for those services and to integrate them and align them with everything else that might be happening within the community. It's also something that is happening nationally. So this is a very colorful map. So the CCBHC model was established, was really launched in 2017 and has slowly grown over time. The states that are in orange launched in that initial cohort of states, but we're seeing states being prepared for that next launch, which will happen in 2024. So those are states that are in this turquoise green color, and then some of them that are in the blue color. Ones that are in yellow have passed policies that will set the state up to establish the model independently. And then those who don't have a color associated with them have not had anything happen yet. But it's important to note that the CCBHC model has kind of 2 major funding streams. One that is around Medicaid. So again, that payer for folks who are for indigent care by and large, but then this is the largest payer and the ability for which many of the folks who work within the safety net who are providing those services are looking at. DC is a state that has a grantee, but does not yet have either a planning grant or state level policies in place, so it would be purple. We can go to the next slide. So I want to just show some outcomes that I think would be important for just this conversation. So often when we're talking about 988, we're talking about, how are we going to be hiring people? How do we kind of embed those technologies? How are we tracking these metrics compared to other metrics? How are we kind of seeing how this compares to that within those different kind of capabilities? So this is a national survey that we did last year around CCBHCs, and it's kind of got 2 major components here. One is how many more people are being seen? So what's that increase in access to care? And then are we able to hire more folks? So we've seen across the country for those CCBHCs about an average of 23% increase in access to care. For those states and those providers that have that Medicaid payment rate, that's at a 30%. So about increasing it by a third for that increase in access to care, and that's huge. So that's a third of the folks who previously weren't receiving services either because it wasn't timely, maybe they wasn't the right kind of services necessary for them, or just didn't that accessibility, that kind of population specific care wasn't there. Those CCBHCs are now being able to provide that. And with that, from a workforce point of view, we've seen about 27 new positions be hired at those clinics. So that's not just 27 positions posted on a website, kind of waiting for applications. Those are actual people working, in that clinic and providing care. And so when we're thinking about the ability to provide that mobile crisis response, folks who can be able to kind of work to help and align with 988. This is a mechanism by which we can help to elevate the workforce, support those services, and be able to provide care across the continuum for individuals with mental health or substance use challenge. For the next 2 slides, I just want to give you a snapshot of how this has impacted just one state. So if you're in a state that is a color that is blue or turquoise or yellow, you have the opportunity to have these kinds of outcomes. So I want to put that out there that this is something possible. So Missouri is a state that's been able to increase access by 35%. So again, above that average of 30% that we've seen. They've done it across the board with all of their clinics. They've also been able to do it with some of those often underserved populations, one in particular looking at veterans. So being able to increase that by 23%. And it's been able to increase steadily year over year, as you can see here. In the next slide, you'll see how that's been able to affect and impact the different provider types. So family providers, peer support, psychiatrists specifically for youth, and then also looking at other prescribers. We're looking at kind of doubling the workforce within those areas. And then when we see from a cost savings point of view, the CCBHC model has been able to reduce those costs at about $500 per person. And that's specifically by being able to deflect and divert around those hospital costs. So oftentimes when we're thinking about where and how we can help to support individuals in crisis, being able to provide them community-based services where there's not loud noises, where there's not potentially other triggering types of things to expose them to, that outpatient care center is really a place to provide those high quality services. And so that deflection is really important. The next 2 slides will talk about the updates to the criteria. And I know that I'm speaking fast, and I apologize for that. I want to make sure to get through a lot of the content. But the updates to the criteria really focus on 3 major areas. One is on crisis care. And so you'll see that very first component is this required coordination with 988 crisis centers serving that CCBHC area. So if you are a 988 call center and there is a CCBHC in your area, that CCBHC starting on July 1st of 2024 will be required to have that partnership with you. Now, I'll talk a little bit about the partnership and how that helps with funding. So if there are things that you can share with that CCBHC around your technology platform, around maybe embedding some staff to help to meet those needs. Perhaps you share a building, so those are things that percentage can be covered within those costs. And so therefore alleviating the financial burden around 988 for your area. So the US is a very colorful map. There's lots of policies taking place. That federal criteria to be able to meet that is going to be able to provide, again, a vehicle to financially cover costs around 988 and be able to provide a lot more connectivity around data and such. The other 2 areas that are really important is around the overdose epidemic. So being able to connect to opioid treatment providers, and then also looking at health equity. So ensuring that individuals who are often underserved, we're looking at social determinants of health, when we're looking at kind of communities that may not be served due to language barriers, may not be served due to kind of cultural differences, the CCBHC is required to be able to provide those through community needs assessment. There's also this required kind of quality metrics. And so actually, if you look at some of the research around CCBHC, there's been a number of things kind of saying, well, what has this done and how is it compared to kind of previous efforts? And really those quality metrics haven't really existed in that same way. So CCBHC is really creating the foundation to build that moving forward. So here's a list of those quality metrics that you'll be able to see. For the next 2 slides, so that PPS rate. So a PPS rate, and I know I'm throwing out a lot of acronyms for our friends here, but it's a prospective payment system, which is a rate that the clinic gets paid either on a daily rate or a monthly rate that covers the anticipated cost of delivering services in that area. So it makes sure that clinics aren't running in the red and aren't having to pick and choose which programs they're going to be doing. So whatever is really necessary to thrive within that community, that can be built into either that daily or monthly rate. So the next slide we're looking at that clinics or that states rather now have the opportunity or may potentially have the opportunity, depending on kind of what is updated by CMS. The next slide will be able to kind of have things around crisis kind of carved out within that. So this is something that's proposed for CMS currently. And so we might be able to see as a number of states are looking to have separate crisis systems, separate mechanisms paying for kind of those components around mobile crisis and other related efforts. They'll be able to have that CCBHC payment experience as well without having to affect what they've already got in place potentially. The next two slides, and then I'm ready for questions, or we can move to our roundtable, are talking about how although the next cohort is in 2024 and it's available for 10 states to join it, states are also able to build this independently, and there's future opportunities. So in 2026, 2028, 2030, for states to then join that demonstration. And so again, when states join the demonstration, they get an enhanced rate within Medicaid, so they're able to save some money in that way. They're also able to, again, build in those costs that are allowable for things that can help to alleviate the financial burden on the state related to crisis. So there's a number of states doing things outside of CCBHC for 988 and other crisis-related efforts. This will help to connect those services and connect those dots. The next slide is a bit of a Gantt chart to let folks know kind of where things are. So when I was asked, when do you want to present, around CCBHC, the September time was really perfect, because as you're seeing right now, states are starting to formalize their criteria. So what are those things that they're going to be able to allow to cover within CCBHC? So those services, those staff, we're thinking about the workforce shortage. So what kind of staff are going to be able to be in there? What other staff? What are kind of bonuses, incentive payments, salary increases that we're going to be able to do? And then how do we build that into those PPS rates? So if you're currently in a state that's either that blue or turquoise color, reach out to the clinics in your area, or reach out to your state and see how you could be involved and make sure your voice is heard, because there'll be a lot of opportunities for some comment to seeing where and how what is important to you all as relates to 988 and other crisis related services can be built into it and be able to help serve in a very community specific way. So I think I got it all in within my 15-minute time frame. So I appreciate it, and I'll turn it back over to you, Aisha.
You sure did, Brett. Thank you so much. I'm going to bring up our first roundtable discussant, David Dvorsny. Are you here with us?
Yeah, I'm here.
Hi, David. Let me pass to you for your reactions on what you heard from Brett.
First, it's always great to see Brett. So thanks, Brett, for a great presentation, and certainly a man who knows a lot about CCBHCs. Happy to see him on one of several calls we seem to have every month. So, I think there's a really tremendous potential for synergy across the 988 and crisis systems that states and localities are developing in CCBHCs, and I think CCBHCs can and will be an integral part of that. And so we're happy to have this time to talk with you a little bit about CCBHCs. I do want to just provide a couple more details about the CCBHCs just for the audience. I think it's really important to understand what happens when a person first contacts a CCBHC and what is mandated to be a part of that service package that CCBHCs provide. So at first contact, whether it's someone walking in the door of a CCBHC, someone getting a referral to a CCBHC, somebody just calling the CCBHC off the street, even getting a referral through the 988 system. The CCBHC's first responsibility in that moment is to identify, is this person in crisis? And if that person is in crisis, CCBHC is required to provide, either directly or through a formal relationship with another organization, a mobile crisis response within 3 hours. And so, and that's not where it ends. Once they have that mobile crisis response, they're responsible for providing care coordination to connect people back to a comprehensive package of services, 9 required services that are part of a CCBHC model. If you really want to understand what a CCBHC is, the most important thing you can do is just go on Google and Google CCBHC certification criteria SAMHSA. It'll bring you to your site, and the certification criteria that really explain what CCBHCs are on that site. It's about a 65-page document, so it's great bedtime reading because it will put you to sleep, but I guarantee you in a couple evenings you can make it through it, and it's really a good way to understand the model. If you're interested in the crisis provisions, you can just kind of do a word search for crisis. That'll bring up a lot of the relevant provisions. A lot of the relevant provisions just happen to be lined up in a really neat way. There's 6 main sections of the criteria. The second section is an access requirements section. It's in 2C is the crisis part of that. The second section is a care coordination section. There's a requirement that CCBHCs develop a care coordination partnership with their regional 988 center. That's in 3C of the care coordination requirements. And finally, the service definition for those CCBHC crisis requirements are located in 4C of the certification criteria. So if you just go to 2C, 3C, and 4C, you'll be able to find a lot of the really meaty requirements around crisis. CCBHCs, as I said, have since the beginning of the program in 2017 had to provide that mobile crisis response. With the updated criteria, we've also required that CCBHCs, we've tried to align the crisis requirements with the SAMHSA crisis guidelines. We've added a requirement CCBHCs have some kind of crisis walking capacity and that they're also coordinating with their local air traffic control systems. And so really important to understand, that there are these really substantive requirements around coordinating with crisis. Actually, there's a question in the chat. The best list of CCBHCs available publicly is actually on the National Council site. I think if you type in CCBHC locator, you should be able to find that through their site. And so I just want to make clear that if a person comes into contact with CCBHCs, they should get connected with a crisis response if they need one. That connection can obviously come through 988, and it is happening in a lot of places. I was just in a CCBHC in New York, and they're actually noting all referrals that come through 988 so they can track them in their system as a part of the electronic health record system. And then, again, people are going to get connected to this follow-up set of services. And just to give you a sense of what happens after a person gets in contact with the CCBHC, they have to be seen immediately within a crisis. For everybody else, they have to be seen within 10 days. They have to have a comprehensive assessment completed within 60 days of contacting the CCBHC. That assessment then goes into a treatment plan that has to be updated no less frequently than every twice a year. And other times when it would need to be updated based on changes in kind of clinical presentation. We're really excited. We have now CCBHCs, about more than 500 CCBHCs across the country. And Brett really highlighted, that we're looking at increased spread. Right now we have 8 states with established CCBHC demonstration programs, 3 states that have really established programs outside the demonstration. We're going to be adding 10 more states with demonstration programs, on or after July 1st, 2024, and then another 10 states in 2026. And what that means is we're on track to be in more than 30 states in 2 years with state CCBHC programs. So this is a model that's going to be growing, and I think really understanding the importance that this model has for crisis systems, not only for helping with the initial crisis response, but also that really important follow-up care is I think what you're going to take one thing away from this, that CCBHCs are coming if they're not already where you are, and they can really be an integral part of that crisis system. So that's
fantastic, David. Thank you so much. Thank you. And then I just want to point out there's a ton of questions, Brett, David, that are coming up in the chat. So if you are able, I think folks would love some responses there. But also next, I'd love to bring up Vic Armstrong. Vic, are you with us to give your feedback and reactions to what you just heard from Brett and David?
I am. And first of all, I do want to thank Brett for such a great presentation and really explanation of what CCBHCs are. I have for a long time been a fan of CCBHCs for a number of reasons. One is because throughout my career, CCBHCs are probably the first thing that I've seen that really gives us a template for what a system of care should look like. And that has been something I think that we struggle with in the mental health field forever, in that mental health services can look so different from state to state. And I think CCBHCs can be a template for not only what the system of care can look like at present, but also potentially what it can look like. Because as we continue to think about things like 988, CCBHCs can be the thread that holds all those things together. The other thing I love about CCBHCs is I love the fact that they really focus on how you embed services into a community, and the community being a part of that. And so again, I think the beauty of that is that it's not just what CCBHCs are, but what CCBHCs have the potential to be. And as Brett was sharing about some of the updated criteria, I love the fact that he focused on one of those things being the inception of 988, and how 988 immediately becomes a part of that CCBHC system, and then also being able to respond to the overdose epidemic, because again, it provides a template for how we can respond for things that as things change on the horizon, CCBHCs have the flexibility to be able to address those changes. And then finally, the health equity piece, which is something that is extremely important to me. And I think that as we think about the potential for CCBHCs, I think one of the things that CCBHCs also allow us to do in that equity space is it allows us to really think about things in a way that we haven't traditionally thought about things. And that is that sometimes when we talk about moving healthcare or behavioral healthcare forward, we don't often ask ourselves the question of moving forward from where, because we don't think about the fact that not everyone begins from the same starting point. And oftentimes we don't think about those things because we don't have the flexibility to meet people where they are. And I think CCBHCs being embedded in communities and with the potential to really partner with communities, with the resources that already exist in communities, CCBHCs are in a very unique position to be able to help us to meet people where they are, and to recognize that sometimes we can, in moving healthcare forward, we can inadvertently increase that equity gap. And by being able to utilize the CCBHC model and tailor our resources to the community and tailor our response to the community, I really think it gives us a very unique opportunity to partner different with communities, to look at how do we embed those existing resources within communities into our model, but also to be able to fill in those gaps as they look different in those different communities. So again, I applaud the work that the National Council has done and all the different entities that are involved in really helping us get the CCBHC model to where it is now, all the partnerships, SAMHSA, different organizations like that. And I'm just extremely excited about where we go from here. Thank you.
Thank you so much, Vic. That's a great reminder that this is a model that can be both flexible to people's needs, but also really deeply rooted in a community and responsive to the needs of communities that have not always been responded to effectively. So thank you so much for those reflections. Next, I would like to turn us to the SAMHSA update. Dr. Richard McKeon, are you in the house?
I am here. Thank you very much. And I loved hearing about the CCBHCs and the connection to 988. I mean, these are two of SAMHSA's most important initiatives, and they complement each other extremely well. So thanks to the Crisis Jam for focusing on that today. Just a couple of things I will mention. SAMHSA has awarded 5 National Strategy for Suicide Prevention grants. This is particularly interesting, I think, and important because I think these grants have the strongest language about reducing access to lethal means in any of the notice of funding opportunities that SAMHSA has put out previously. So we're really glad about that language. Also really specifically identifies the importance of suicide prevention among older Americans. And as we proceed with the anticipated March 2024 release of the revised National Strategy for Suicide Prevention, I think these grants are of particular importance. Also be alert in the days ahead for more SAMHSA suicide prevention and crisis-related grants coming out. And as David mentioned, more CCBHC grants, zero suicides, the state 988, tribal 988 grants, so that there'll be a lot of activity between now and the end of the month. And of course, we are coming up toward World Suicide Prevention Day. And that's really important for people to be aware of. I also wanted to make sure that people were aware that from now until September 11th, that the Center for Medicare and Medicaid Services have asked for public comment on their calendar year 24 Medicare physician fee schedule. And they have some specific language about crisis and suicide prevention services. And I will put this in the chat, but the text regarding states, additionally, we are seeking comment on whether there is a need for potential separate coding and payments for interventions initiated or furnished in the emergency department or other crisis settings for patients with suicidality or at risk of suicide, such as safety planning interventions and/or telephonic post-discharge follow-up contacts after an emergency department visit or crisis encounter, or whether existing payment mechanisms are sufficient to support furnishing such interventions when indicated. So this is really important, right? That CMS is asking whether there is a need for separate coding and payment interventions for emergency and crisis settings. So everyone should weigh in with CMS because they're wanting to know what the field thinks. So thank you very much for the opportunity to give the SAMHSA update.
Thank you
Great.
so much, Richard.
Oh.
Next.
Sorry, is it possible to add two very quick things from SAMHSA side?
Oh, sure. Is that David talking?
No, this is James Wright.
It's James. Right. Okay.
Yep.
Go ahead.
So I did want to make sure people were aware, number one, before the end of the month, we are going to be releasing the awards for the 3 grant programs that we offered. This was roughly the $200 million for the new fiscal year funding for the state, territory, the tribal programs, and the crisis center follow-up. And then finally, we did talk about this on a recent crisis jam, but really the need for the continued expansion of Lifeline services. We are pleased today to do a soft launch for ASL services through the Lifeline website. So those services, again, are in a soft launch today, but are live for individuals wanting to access through directly to a counselor through American Sign Language. And you can access that service through 988lifeline.org. So I just wanted to make sure to share that, and a more public announcement after the soft launch will be coming within the next week. So super excited that we got to move that forward. Thanks all.
That's great, James. And maybe if you want, drop the link in the chat as well. Brian Hepburn, bringing you up for the NASHFIT update. Bring you back.
Thank you. And just real quickly, I want to thank SAMHSA for their leadership and for the information regarding CMS and also about the 988 soft launch. I know that that has Megan jumping up and down regarding the ASL services. So thank you. Want to thank Brett, David, and Vic regarding the CCBHCs. Also thank SAMHSA as well as the National Council for their leadership on the CCBHCs. NASHFID will continue to work with SAMHSA and National Council to make sure that all states are aware of the model, the CCBHC model, and the advantages of that model when it comes to access to care, specifically related to crisis services. So thank you all, and back to you, Aisha.
Thank you, Brian. Short and sweet there. So next, I'm bringing up, I think, Sarah Cochran, you're with us today, correct?
Sarah is not here today, but I am. I will cover a quick overview for everyone. We've been a little quiet on the federal side as Congress has been in recess. The Senate should be back this week, and then the House will come back next week. So hopefully next week we'll have a little more of a concrete update for everyone. But for now, just want to give a quick overview of where we are in terms of appropriations this year. As everyone knows, the fiscal year currently will end at the end of September. And unfortunately, so far, neither the House or the Senate have passed a labor age bill, nor have they passed any of the other 11 subcommittee bills. So we are sort of waiting on hold. For the House, we've seen full bill language. For the Senate, we've seen the reports and the bills. So we have a little more detail in that. And you can see in this slide here that Sarah put together for us last month. We are looking forward to expecting probably a short-term CR, a continuing resolution, to keep the government operating from September through December. This seems likely. Unfortunately, as we know, this is a pretty tricky year in terms of House and Senate agreement. There have been a lot of disagreements, a lot of demands that we are expecting may delay things. A shutdown is possible. But again, hopefully we'll have a little more information to report back next week. In terms of the bigger picture, the debt ceiling bill sequestration threat is sort of looming a 1% defense and non-defense cut from the FY23 levels. And that's if all 12 bills aren't passed and signed into law by January 2024. So we're keeping an eye on all of this, definitely sort of on our toes, but really hopeful. The Senate numbers looked pretty encouraging. So we are sort of proceeding with our fingers crossed. And that's all I have for you today, but appreciate it. And Aisha, back to you.
Thank you so much, Joanna, for the update. Appreciate it. Next, I'm going to be bringing up, we don't have a state update for you today. However, do we have Stephanie in the audience to talk a little bit about the NAMI advocacy? Just give like 30 seconds on it, NAMI advocacy calls.
Thanks. Just a reminder for folks, NAMI hosts monthly 98 state advocates calls. This is usually the first Monday of every month at 4 p.m. Eastern, but because of the Labor Day holiday this month, our next call is actually this coming Monday afternoon. I will post a link in the chat if you want to sign up for those calls. We are hosting a series of conversations between now and December about how to get ready for 2024 state sessions. So if you're active in your state level 98 advocacy, highly recommend signing up for our calls. So thanks for the time, Aisha.
Yeah, absolutely. Thanks for jumping on the spot. Next, really excited to bring up Stephanie Hepburn and Kevin Berthia. You saw, if you were in the pre-show, you saw a little bit of a video from Moving America's Toll on Suicide. But Stephanie and Kevin also spoke and featured in a Crisis Talk article. So Stephanie, I'll pass it to you too to discuss what you're discuss that article.
Thanks, Aisha. Yes, so I'd like to welcome Kevin Berthia. He's a suicide prevention advocate and founder of the Kevin Berthia Foundation. Kevin, you shared that as mental health stigma lessens, more people are reaching out, but the field isn't yet where it needs to be in order to meet demand. And so you said that means we need to get creative. Can you share your thoughts?
Yes. Can you hear me? Everything? Can you hear me all right?
Yeah.
Sorry about the if there's any noise in the background, just flying in from the airport. So y'all forgive me for this. I'm a little more professional than this, but forgive me. But yeah, definitely. I just think that we have to pull back the layer on mental health and really change things and change the dynamics. With this up and coming generation, so many things are changing. The world is changing and evolving everything, but we're still doing things that we were doing in the mental health field 30 and 40 years ago. We have to get with times and get with how things are changing.
So for you, can you talk a little bit about, the shift in stigma when you were younger? Talking about your emotions was just not something that was normalized. Can you talk a little bit about that and the shift that you saw with COVID?
Absolutely. I'm 40, I'll be 41 this year. And you think 40 years ago, mental health didn't even exist. We never talked about it. Growing up, I never saw a commercial. I never saw T-shirts. I never saw anything that was related to mental health. So I was always felt alone. Now, since COVID, from the last 3 years, we've done more in the last 3 years than we've probably done in the last 50 because we've had no choice. People's, their coping mechanisms are different. Everybody's changing, and we all, for once in our life, have to deal with mental health all at once. And it's the first time. I'm 40. I've never seen the world where we all at one time had to deal with all our issues together, and we were all in this fish tank boat together.
And you shared with me, what was essential for you was compassion and having a conversation with Kevin Briggs. Can you talk a little bit about how that could be integrated today and share, also your perspective on some of the workforce challenges?
I think that the two most important C's that we have to deal with are connection and compassion. Once we connect with people, we have to be compassionate about where they're at and not try to move them to where we're at. I think that once we allow ourselves to connect with people and then be compassionate about where they're at and allowing ourselves, and I think that compassion comes from understanding that we've all been through things in our lives. We've all been through, had that moment. We may not be where this individual is today, but we could have done things in our life that brought us to that moment. So I think the compassion has to come from anybody at any given time, at any place in any world, any place in the world can have a dark moment, can have a bad day, can have a thought of wanting to take their own lives. And so I think that's where the compassion comes from. And the connection part is important because it's almost 9 billion people on this planet. So nobody on this earth should ever feel alone. And I think that in the workforce, we have to get better as far as these two things with connection and compassion, because people, we spend more time at work than we do anywhere else in the world. We see our coworkers more than we do our family. So the connection and the compassion part has to start in our workforce area, because that's where we spend a lot of our time. And if we missing the connection and the compassion, then in that 8-hour, 10-hour time frame that people are there, then we expect them to go all day without that connection. We expect them to go all day without somebody feeling compassionate about them. And people need that, whether we realize it or not. We dwell living in connections with people.
You also talked about how vital follow-up is, and not just for contact or call centers, but you called therapy grueling, and how follow-up could be really integral during that process as well.
Absolutely. I mean, I think that there's not enough follow-up. When people have to open up their emotions and go through this therapy process, I don't think we understand how emotionally overwhelming it could be once you leave. Now I've put everything on the table. Now I got to wait 2 weeks before I talk to you again. I got to wait 2 weeks before I deal with these feelings again. And that follow-up is key to allow people to see, hey, I see you as you are. I validate you for where you're at today, and I see you as you are, and I'm following up to make sure you understand that somebody cares about you. And that follow-up helps people stay connected. The whole point of people feeling alone and isolating themselves is they don't feel connected. If we connect with people, it allows them not only to feel the compassion from people, but feel the compassion for themselves.
We talked about safety net.
Sorry, Stephanie.
No, thanks, Aisha.
No, this is great. And Kevin, thank you so much. Thank you, Stephanie. And you're really calling back to, especially we're hearing a lot today, but Maddie talked about it, that need to really connect meaningfully with other people and to bring your full selves to support folks. So just thank you for the time. Thank you for coming into the airport. Really appreciate it. Just closing out really quickly, Karen, can you come on for 30 seconds and give the update on the Moving America's Soul on Suicide, since you were the production coordinator for this, as I understand it?
Sure, I'd be happy to. We have been working over the last 3 years on the Moving America's Soul on Suicide, and are thrilled to finally have it almost complete and ready to launch for the full-length documentary film. So as part of our launch preparations on September 21st, we will have a webinar at 1 p.m. Eastern, and we encourage everyone to join to check it out. We'll have a couple of our storytellers, hear from our director and producers about why this film is so important on spreading awareness, and we hope you all will check it out.
Thank you so much, Karen. And with that, I will say we will have a new segment starting on October 13th, the crisis debate. It will be focused this first time on the role of AI in addressing crisis and mental health. So tune in for that session, absolutely. And then next, as always, we have a series of fantastic topics. So the next one will be Stephanie Mitchell, who's talking about her experience grappling with suicidal love. So it's going to be fantastic. Definitely be there. And then next, focusing on peers in crisis, is Justin Bolfing and Amy Brinkley. Thank you all for being here. See you next week. And take care of yourselves and take care of each other. Take care. Bye.